Good morning, everybody. I have the distinction of being the very last speaker, so I have to be very, very fast and also very, very interesting because I know you all need a break. So my quick story is people have said how they became interested in working with X and Y variations. I am a nurse practitioner in pediatrics. I went back to Columbia University in New York to get a PhD and was working as a research assistant in endocrinology and was very interested in genetics and metabolism. And through my work there, I became introduced to families with Klinefelter syndrome, families with girls who had Trisomy X. And the reason I became interested in this is because I got mad. I saw these families coming into the clinics in either 6-month intervals or yearly intervals, and I realized that from one visit to the next, they had been going from place to place to place, gathering bags of advice, and not having, the clinicians were not talking to one another at all. And then the next year they would come back and they would collect a new bag of advice. And I thought, that's not right. I think we need to find a different way. So I began studying Klinefelter syndrome. That's what I studied during my dissertation. And since then, I really have become involved in family management of X and Y variations, and I'll explain some of that in a minute. So today we're going to talk about, just as Dr. Reese alluded to, roadmaps to research. And I'll tell you a little bit about what we've been doing here at Emory. So 3 years ago, I received a grant from the Patient-Centered Outcome Research Institute to engage a group of families and patients with X and Y variations over the course of 2 years. During the first year, we worked together in monthly video calls, telephone calls, etc., to kind of plan and get their input for planning of a family conference. And then this was to lead in the second year for a scientific conference, all for the purpose of gathering what is important to patients. Genes are very important. We need that for translational research. We need that to develop interventions, as are all of the other clinical studies. But we also need to know what is important to you. So these are some of the things that came out of some of the focus groups. When I was very touched when a parent participant said, nobody knows about us and nobody is interested in us. And that's how they felt, because you look at, who was it? It was Dr. Wilson, who showed you the number of publications in the X and Y area. We just are not that well known. But the parents and the patients also said, we want you to ask us, what is it like to live this way? What do we want and what do we need? We want you to ask us about our struggles, how we can be involved in research, how we can influence awareness, and also we need you to understand that we need your help now, not later. Many clinical trials start out, and we know that there will be interventions maybe in the next 8 to 20 years. But for a baby that is born today, the parents are saying, my child will be 20 years old before I know what to do about this. So I have become very involved in what are called qualitative and mixed methods approaches. Qualitative approaches to research actually involve interviews with individuals and also with focus groups. And instead of collecting measurements, classic measurements, we're actually collecting words. Words become the data. Your stories are then translated individually, abstracted into meanings, and then we look at similarities and differences across a number of interviews. So these are some of the studies that I've completed since the PCORI grant that finished in 2016. The first one was a study with women with Trisomy X called Health Concerns of Women with Trisomy X. And the reason it's so important that we used a qualitative approach on this is because scientists often think that we know what it is you need, or that we understand what the problem is, and so we'll go ahead and investigate the problem we think is there. So we came into this study thinking, well, women with Trisomy X often have premature ovarian failure, and this can lead to some fertility problems. Women with fertility problems often have depression and anxiety and poor quality of health, etc. So I went into this project thinking, well, this is probably what we're going to investigate. What is it like to have to struggle with fertility when you have an extra X chromosome? But after going through these interviews, time and time, person to person to person, I realized I was really off. They're not concerned with that at all. Their main concern is finding a safe and stable place of caring at home, at school, in employment, and in medical systems. We learned so much more by going to the patient and asking them, what is important to you, than for me to sit back and say, I think I know what the problem is, I'm going to investigate that. The second study that we have just completed is a study with adults with XXYY and also their caregivers. And we find there kind of an assumption that there's going to be some poor quality of life and some struggles, just as we would in every day. However, we found that the main problem was this unpredictable shifting of interdependence, because the guys with XXYY want so badly to be independent, and they often set it up so that they can be partially independent, but then the parent or caregiver has to come in and balance that off when the independence doesn't work. So it's unpredictable which way it's going to go, and this is what's causing the stress in the family and also the patient. We developed in 2017, we found that a lot of parents don't understand non-invasive prenatal screening. They don't know the difference between a screening test and also a confirmatory test. So working with our genetic counseling program, we developed an online module and just tested it to see if it would help reduce stress and anxiety if parents could learn about the difference between risk and also confirmation of having an X and Y variation. Working collaboratively with the Mayo Clinic, we just completed a study on family experiences learning the diagnosis of X and Y variations. And in that study, we looked at postnatal knowledge and support and found that by and large, people are learning about this diagnosis from clinicians who don't understand it at all. Not many genetic counselors are available to explain these results to a lot of parents who get these tests. Many parents go in simply wanting to find out the sex of their child, and then they find out adventitiously that they're at risk for having an X and Y variation. And then they go back to their primary care provider, or they're referred to another specialist, and none of those people really understand what's happening. So this is helping us understand that we need to get our continuing medical education out there for all specialists and all primary care providers, and especially those who are informing people with these results. And we also very much need to improve our information and support as they appear online and also in print, because as Dr. Rogel brought up, Dr. Google is not necessarily very accurate. We really need to make a concerted effort to change these things. And then also a shout out to a PhD student here who's with me today, whose dissertation is focused on the relationship of physical and psychosocial health on quality of life in men with XXYY. So going back to the chart that Dr. Wilson showed you, where we have all this autism literature and all this Fragile X literature, you can see that we are slowly growing, but getting there. So what's the future? What have we learned from this qualitative by going back to the patients and the families and saying, what is it that you want us to study? These are the things that come out. Mental health is huge. Understanding anxiety and depression and what to do about it now. Not so much the source of it and the genetics part of it, but patients want to know, what do I do about it now? Physical health is very important. There are a lot of symptoms for which there is no literature. There is a lot of pain in this community of patients that has not been addressed in the literature. Social interaction difficulties and issues, school, educational issues, transition from childhood to adult. What do we do after the child is 18 and goes into the transitional years of 18 through 24 and then beyond? We have to figure a system of how to provide medical support and other supports for them as they go into their adulthood. Issues with independent living. Some kids are going to be able to go out and go to college and have jobs and just be able to be independent, and others are going to require some support from their families. So what can we do to anticipate this possibility, and what can we do to intervene to help them become as independent as possible? And if they can't, what do we do to intervene to help the caregivers along the way? So this leads to the caregiver issues. So focus and expansion on intervention development. From the interviews, we learned that depression is really important to investigate further, self-harm and suicidality, anxiety, substance and media addiction. In the XXYY studies that we have just completed, we know that there is a lot of socialization that happens online or just with video gaming, etc. So this is an area of study that's really important. Physical health. Fatigue is an issue, pain, tremor, inflammation, immunity and inflammation, and also reproduction. Those are areas that we need to investigate more deeply. And then social interaction, facial expression recognition. Dr. Sophie Van Ryn does all of these things. Communication interpretation, communication reciprocity. What kinds of interventions can we develop that we can plug in early so that we can help these children before they get to this stage where social interaction is so poor that they're not able to do well in school or do well in their jobs? Other interventional development ideas would be comparative educational approaches. Universal design, for example, is something that is used in many schools, and there is a trial going on right now at Emory University on a social engagement, knowledge, and support model to add to that kind of shows it's almost like you were teaching children at risk of autism, but they're typical children. And if you give them competencies along the way, then children will engage with their learning early. So that's a possible intervention that we could be using in our population. So comparative educational settings. Is my child better in a special education program, a self-contained program? It's all kind of individualized, and we have to figure out what are the features of those children that enable us to anticipate which educational setting will be important for them. And then teacher trainings are very, very important. Schools are difficult. Schools often will stand on their own and say, you know, this is our school district, this is how we do things, and parents often have a struggle with this. At Emory, we developed a school training for parents who are having struggles with their teachers and auxiliary personnel in the school. And even though I have done many of these where the administrators have been present and the teachers, et cetera, and it's gone very well, but then we also have school districts that say, we don't need to hear that, we know what we're doing, we really don't need to understand this X and Y thing because this is just the way we teach students. So we have to do a lot more about teacher trainings. So let's see. Okay, we already did educational issues. Transition to adulthood, transitioning toolkit development in pediatric and adult provider trainings, toolkit development for independent living, and then support for caregivers and all these things. So mapping the research landscape looks like this, discovering and deeply investigating what the problem is. We really can't develop interventions that go well unless we understand truly what the problem is. Individual team inquiry at University of Colorado, at Stanford, at Emory, whatever, but also team collaborations are extremely important. And then finally, growing the research enterprise by promoting this interest contagion. We need a lot of people doing this to increase the amount of evidence that we have out there so that we can understand better. We need to attract and support new researchers into our community. And then we need to combine with other conditions, such as Fragile X and autism, that share some overlapping features and problems. So I just want to leave you with a quote from a person I admire who is a logician, philosopher, and a theoretical biologist, and he said, this is one of his famous quotes, sometimes it is the people no one can imagine anything of who do the things no one can imagine. And so you are those people. The research questions, the interest, the participation is actually going to come from you. So let your needs be known. Partner with the clinicians and researchers in the United States and beyond. And then remember to participate in research, because that's where we're going to find the answers. So we also appreciate, as researchers, your help in getting others to participate in research, because we need big numbers sometimes as well as small numbers. And so thank you.